For your patients with hard-to-control hypertension, are you struggling to achieve blood pressure goals despite treating with at least 2 antihypertensive medications? Uncontrolled hypertension increases the risk of death and stroke for many patients. Not all hypertension is the same. For many of these patients, you may want to consider a different pathway. Aldosterone may be to blame. Visit blamealdo.com to learn more.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hi, everyone. This is Colin again, coming to you with another amazing CNCR case report from really great people at Trinity Health Livonia Hospital and Michigan State University. I'm here with the one, the only co-founder of CardioNerds, Dan Ambinder. How you doing, Dan?
God, I'm doing so great, and you're too kind. It is so much fun to do one of these recordings with you, and I am just so excited to be here. So thank you so much for hosting this wonderful episode.
I'm excited for all the learning that's about to happen. First, introductions as always. Let's start with meeting all of the amazing people from both Trinity Health Livonia Hospital and Michigan State. You guys want to introduce yourselves?
Hi, thanks, Colin. Thank you so much for that introduction. I am Juma bin Firos. I'm a PGY2 internal medicine resident at Trinity Health Livonia Hospital with a passion for cardiology, especially interventional cardiology. And I'm so excited to be here.
Hi, and I'm Aishwarya Verma, cardiology fellow at Michigan State University and an incoming electrophysiology fellow at Loma Linda University. Nice to be here.
We are so excited to have you guys. There is so many beautiful things in and around Michigan. Set the scene for us. Where are we going to talk about our amazing case for today?
Thanks, Colin. So, Colin, today we are going to talk about a complex yet extremely fascinating case involving a young 30-year-old male who seemed perfectly healthy, yet kept having these really dangerous ventricular arrhythmias during exercise, eventually leading to cardiac arrest. And the thing is, he didn't have any of those usual risk factors you would normally look for.
And I think that's what makes these cases so challenging and important to understand. I think we've got quite a bit to draw on here. His medical history, the whole diagnostic workup, EKG, cath lab results, echo, EP study, and cardiac MRI, of course. Plus how things played out clinically and some expert perspectives too.
Exactly. And for everyone who's listening to this, our mission here is to really unpack why someone young, seemingly fit, can be susceptible to these life-threatening arrhythmias.
We'll look at the crucial role these advanced electrophysiology studies play and the key things cardiologists consider in managing cases this complex. Hopefully give you some real insights into the intricacies of cardiac electrophysiology. And before we jump in, let's share our favorite Southeast Michigan spots. Like, Ash, where's your go-to?
Well, Juma, for me, it's the Detroit Riverwalk, of course. The best riverwalk in the nation. Perfect for a post-fall sunrise. What about you?
For me, it should be the Detroit Institute of Art. Great for pretending that I'm cultured and then taking a stroll in Dearborn Heights with a cup of Adani chai from Kawa House. It's a must, and we shall all get together there sometime after this episode.
That sounds like a plan.
All right, let's get started. It kicks off when this 30-year-old man is brought in after an out-of-the-hospital cardiac arrest, ventricular fibrillation on exercise. And crucially, this wasn't a one-off. Back in 2021, he had an episode of sustained monomorphic ventricular tachycardia. That episode was also induced exercise.
Wow. So a recurring pattern specifically tied to exertion. That really narrows the focus. So for this latest event, what was the immediate response?
Well, EMS got there fast. They did CPR, gave multiple rounds of epinephrine, and amiodarone, and thankfully they got his pulse back.
But he was very unstable. He gets to the emergency department and goes back into ventricular fibrillation. They had to defibrillate him, shock him to get a rhythm back, plus more medications, sodium bicarb, calcium chloride, and more amiodarone. Sounds like it was a real battle to stabilize him initially. I imagine the initial blood work reflected that stress.
Well, absolutely, Ash. The labs were pretty deranged. Severe acidosis with a pH of 6.81, low bicarb at 18.5, a high anion gap of 23, just classic signs of major metabolic distress. His blood sugar was also high at 334, which might be stress hyperglycemia. And there was signs of some organ impact too. His creatinine went up to 1.5, suggesting kidney strain. Magnesium was high at 4.2, while the potassium and calcium were okay.
And what about the troponin?
The troponin was elevated at 1636, and the lactate was also very high at 6, both pointing towards significant heart muscle strain and lack of oxygen delivery. And also a few other things. He had mildly high leukocytosis of 14.0, maybe stress or inflammation related. His hemoglobin was normal, platelets were slightly low, and his coagulations were normal. Interestingly, his thyroid tests were off. He had a high TSH of 21.9 and a low free T4 of 0.6.
Hypothyroid picture, huh? That's something to note. Although may not be the primary trigger for the VF itself. It's a really complex metabolic snapshot. So with all that going on, what did they find when they looked directly in his heart?
So while they did an EKG, the first EKG was suggestive of maybe some ST elevations in V1 and T wave inversions in AVO. The repeat EKG showed more definite ST elevation in V1 and AVO. They immediately took him to the cath lab for a coronary angiogram, but the coronaries were completely normal. Even the left ventricular filling pressures, they were normal too.
Right. So no signs of ischemia. That's huge. Immediately makes you take a step back and think about what is really going on with the heart muscle or the electrical system. What about the echocardiogram?
It showed mild global hypokinesis. EF was measured at 40%, so reduced. But importantly, the echo didn't show any signs of major structural problems. No valve issues, no obvious thickening or dilation, just reduced function. And you mentioned he was active, correct? And no substance use?
His family said he had good functional status, no alcohol, smoking, or illicit drug use. So you've got this picture of a relatively young guy, fit, with no traditional risk for recurrent exercise induced arrest, yet with reduced ejection fraction and no other obvious structural cause identified on the echocardiogram.
It really forced them to dig deeper. You mentioned that 2021 episode. What did they learn back then?
Well, interestingly, during that admission, while he was on telemetry, which is kind of a continuous heart monitor, they picked up some recurrent runs of non sustained monomorphic ventricular tachycardia.
Oh, and they caught it on a full EKG too during one of these sustained episodes. The EKG was key here. It showed ventricular tachycardia had a specific pattern, a right bundle branch block morphology, and a northwest axis. That specific combination strongly points to the ventricular tachycardia originating from the basal inferior part of the left ventricle, probably near the mitral valve annulus.
So the EKG pattern itself was like a clue to the location. Did they do more in depth testing back in 2021, like an EP study?
Yes, they did an electrophysiology study, and it was quite revealing. Using substrate mapping with a penta-array catheter, they found these late abnormal ventricular potentials right in that same area, the basal inferior left ventricle near the mitral annulus.
Ah, the late potentials. That's significant. Think of it like finding frayed or slow wiring in the part of the heart muscle. These are the areas where the electrical signals travel slowly, often through the scar tissue. It's a hallmark of an arrhythmogenic substrate, tissue that's prone to setting up these dangerous re entrance circuits, like an electrical short circuit. Did they do any imaging back then?
Yes, Ash, a cardiac MRI was done, which showed subepicardial late gadolinium enhancement, or LGEs, in the lateral and the inferior walls. LG shows up as bright areas on the MRI after giving contrast. So it basically highlights areas of fibrosis or scarring in the heart muscle, and subepicardial scarring, which is typical for scarring left behind after something like possibly myocarditis.
So the MRI confirmed scar in roughly the same area the EP study pinpointed as electrically abnormal. The pieces finally start to fit together. Scar tissue seen on MRI corresponding to abnormal electrical signals found during the EP study in a location suggested by the VT pattern on the EKG.
Back in 2021, with this evidence, the sustained VTAC, scar tissue, abnormal potentials, the standard of care would be a strong recommendation for an ICD for secondary prevention because he had already had a life threatening arrhythmia.
But he didn't get one, did he?
Unfortunately, no. The report says he opted for a life vest instead as intern protection, which is a wearable defibrillator. It can provide temporary protection, but it's not considered a long term solution for someone with this kind of proven substrate in arrhythmia. And sadly, about 2 years later, he had this recent exercise induced ventricular tachycardia leading to cardiac arrest, despite presumably having the life vest available.
It really highlights the limitations. Compliance can be an issue, and it's just not the same level of protection as an implanted device for someone who's clearly at a high risk of having recurrent arrhythmias.
That's correct, Ash. So, what's been his course during this current hospital stay after the arrest?
Well, he was intubated on a ventilator in the ICU, needed continuous drips of amiodarone and epinephrine initially to keep things stable. He was on the ventilator for 8 days before they could extubate him. Neurology saw him and confirmed mild to moderate anoxic encephalopathy. So he started neurological rehab, and unfortunately, he developed acute renal failure during his stay.
That's right, his kidneys took a hit, likely acute tubular necrosis from the shock and low blood flow during the arrest. Did he need dialysis?
Yes, he needed temporary hemodialysis. But the good news is, they were eventually able to wean him off as his kidney functions recovered, and he was then transferred to an inpatient rehab facility.
Well, that's amazing. And what was the plan after that?
Well, the plan was for outpatient follow up with electrophysiology to yet again discuss about implanting an ICD.
Right, a conversation that's unfortunately long overdue.
It really is. So, our first big question: why are young, seemingly healthy people like him at risk of having these dangerous ventricular arrhythmias? What's going on under the surface?
Ash, that's the $1 million question in cases like this. One major player, as we saw here, is myocardial fibrosis, that's scarring, which was thought to be due to prior myocarditis. Even the LG on the MRI points towards that diagnosis. Even if the overall ejection fraction looks okay or just mildly reduced, the presence of the scar detected by LGE is a huge risk factor. It's found in a lot of non ischemic cardiomyopathy cases.
And does it really increase the risk?
Dramatically. Studies suggest that LGE can increase the risk of sudden cardiac death maybe fivefold or even more. And the location we saw, the subepicardial, often inferolateral, is quite characteristic for these post inflammatory or certain cardiomyopathy scars. It's like a hidden electrical hazard.
We also have to think about subclinical cardiomyopathies, underlying heart muscle diseases that haven't fully declared themselves yet, maybe haven't caused major changes in heart size or function as visible on an echocardiogram, like early stages of genetic conditions like arrhythmogenic right ventricular cardiomyopathy or conditions linked to LMNA gene mutations. These can sometimes present first with ventricular tachycardia even when the ejection fraction is normal.
So the arrhythmia itself is the first sign of something wrong with the muscle. What about purely electrical problems like channelopathies?
Absolutely. The channelopathies are crucial to consider. Things like long QT syndrome, Brugada syndrome, CPVT, short QT syndrome. In these conditions, the heart structurally looks normal, but the problem lies in the ion channels, the tiny electrical gates in the heart cells. It's like faulty wiring in a structurally sound building.
Very interesting. And what about inflammation?
Yes, active or past inflammation, myocarditis like we suspected in our patient, or infiltrative diseases like cardiac sarcoidosis. These can create inflammation and eventually scar, forming that arrhythmogenic substrate we talked about, the breeding ground for arrhythmias.
That's a great explanation, Ash. So, summing all of this up, scars, subtle muscle disease, electrical channel issues, or inflammation, lots of possibilities. It requires a systematic approach to figure out which one or maybe which combination is at play here.
Which brings us to the EP study. How valuable was that in this case, especially for sorting out if this was scar mediated versus a channelopathy?
While the EP study was critical, finding those late abnormal potentials during substrate mapping is a very strong indicator of a scar mediated reentry mechanism, the faulty wiring causing an electric loop. Those late potentials have high specificity, almost 92%, for identifying these slow conduction zones with scar tissue that allow these reentrant loops to form.
And you wouldn't typically find those in a channelopathy?
Generally, no. In channelopathies, the problem is usually abnormal ion channel function, not typically fixed reentry circuits within the scar. So, finding late potentials really points towards a structural scar based problem.
That's a really clear distinction. And you mentioned the EKG pattern of the VT itself was a clue. The right bundle morphology with a superior northwest axis.
Yes, that morphology strongly suggested the origin was in the basal inferior left ventricular wall, which lined up perfectly with where they found these late potentials and where the MRI showed the scar. Different VT morphologies point to different origins. For instance, a left bundle branch block pattern might suggest an origin in the right ventricle or the septum. So, analyzing the VTAG morphology is the first key step.
Did they do any voltage mapping too?
They often do. Electroanatomic voltage mapping creates a 3D map showing the strength of these electrical signals. Areas with very low voltage, typically less than 1.5 millivolts, usually correspond to a dense scar. Here, everything lined up VT morphology, potentials in the MRI scar evidence all pointed towards a scar mediated VTAC from that inferolateral left ventricular region.
Wow, that sounds like a very thorough workup. So now let's tackle this exercise link again.
Guys, this is an incredible case. You don't often see young patients. This is a 30-year-old male who, as far as we know of prior to his previous episode, had no significant medical history, no cardiac history. This is not what you normally see. We are taught 85-90% of VT is happening in the setting of structural heart disease, which is often ischemic or non-ischemic related, often in people who are 50s, 60s, 70s. So it's such an unusual case to see ventricular tachycardia in a patient this young. And I just wanted to briefly touch on and get your thoughts on how do you approach this patient? You guys did an incredible job with the most important thing, which is stabilizing the patient. As the patient comes into the ED, you have to make sure that you are resuscitating the patient, stabilizing the patient, and ruling out acute, important, urgent matters like a STEMI. And you guys did a great job of that. And then once you get to the intensive care unit, the dust sort of settles a little bit and you have to figure out what is actually going on here. And there are a couple different ways you could approach this in a patient who is this young. One is polymorphic VT versus monomorphic VT. Another one is structural heart disease versus no structural heart disease. And there are a whole bunch of different things that can go into either one of these categories. You know, when you're thinking about various channelopathies and VT that happens in patients without structural heart disease, you're thinking about patients who have things like Brugada, long QT syndrome, who have idiopathic VT, who have PVC-induced VF. A lot of these present with polymorphic VT, which could degenerate into VF and could lead to a picture like this. CPVT, which is catecholaminergic polymorphic ventricular tachycardia, is also a very important thing to think about, which typically is inherited and has family history. But this patient has now had multiple episodes of VT during exercise. You have to think about whether has he been genetically tested for his CPVT? Does he have a family history of other people who have had polymorphic VT or exercise-induced sudden cardiac death? So what was your framework? How did you approach this? And how did that inform the next steps, the imaging studies, the way you put this picture together?
That's a great question, Colin. And in this intriguing case, we all were at a loss and genuinely concerned for this young 30-year-old gentleman who had recurrent cardiac arrest, which you can believe is a very significant impact on a young patient like him. Well, initially, when we ruled out coronary artery disease, we next wanted to look at how the heart looks structurally. So the next step was to do an echocardiogram. An echocardiogram revealed the low ejection fraction. Now, the most common cause of low ejection fraction is coronary artery disease, which was already ruled out by cardiac catheterization. And the next thing it makes us want to believe is this could be due to multiple shocks that he received while resuscitation, or this could be some kind of cardiomyopathy that needs to be looked at more closely. So, our next step or our next thought process was to do some more detailed imaging that can give us a clue if there is a scar that may be responsible for this re entry arrhythmias like the ventricular tachycardia he presented with. We did have a comprehensive family history. Apparently, he had no family history of sudden cardiac death, and genetic testing was ordered, but we didn't have enough time to rely on the results of the genetic testing. And since he kept having these non sustained episodes of ventricular tachycardia, we were confident that this could involve more of a re entry mechanism of the arrhythmia. So the cardiac MRI really clued us into what the cause of this arrhythmia could be, as we could directly visualize the scar which was causing these re-entry circuits. Plus, the morphology of the ventricular tachycardia that we saw on the EKG linked very well with the MRI findings. And we were hopeful that we had hit the bull's eye. And so we decided to take him to the EP lab and perform a comprehensive EP study to confirm our suspicion.
And these are really great points. You talk about putting together a story that makes sense. Obviously, it is possible for patients to have multiple things going on, but a parsimonious unifying diagnosis in most patients is the right diagnosis. And you have a lot of very important points. You mentioned there's this beautiful EKG, which people will be able to look at on the website, which is a very stable, mostly monomorphic, essentially completely monomorphic ventricular tachycardia. That automatically makes you think less of things like CPVT. You already also talked about not having the family history, and less of long QT syndrome, which should result in more polymorphic arrhythmias. This EKG, for those who are not able to see it online, is right bundle, right superiorly directed with a V4 transition, meaning that it transitions from mostly positive to mostly negative in V4. And I won't go through how these are localized, but the very brief of it localizes superiorly directed. So it's coming from bottom to top, and it's negative in one. So it's coming from left to right. And this right bundle with a V4 transition puts it in the left ventricle and a little bit off of the mitral valve. So I would say sort of mid left ventricle. And this is not the classic morphologies for things like idiopathic VT. These are RVOT VTs. These are fascicular VTs. This is not a classic morphology for any idiopathic VT. So that already makes you very suspicious that this is something that is going to be substrate related. It's in an area of the heart where you just wouldn't expect a idiopathic VT to come from. So I think you guys obviously are already cluing in on very important, subtle, but very important details to guide your management here.
That was a great explanation, Colin. Very well put. Like we said, the most important and the most simple test to guide us to the diagnostic pathway is that initial EKG. Like always, we have to look at the pattern. If it's monomorphic, it's mostly like a scar-related or a re-entry mechanism, whereas a polymorphic would just point towards channelopathy, like you mentioned. So that kind of led us to pursue further EP studies to look for that arrhythmogenic substrate.
Wow, that was a really in depth study. So now let's tackle this exercise link again. Why does exercise specifically seem to bring these arrhythmias out in some people? What's the trigger mechanism?
That's really important aspect. Exercise triggers a cascade of physiological change. A big one is the sympathetic nervous system surge, the adrenaline rush. That increases the heart's oxygen demand, makes the cardiac myocytes more irritable or automatic, and can unmask hidden conduction problems that aren't obvious at rest.
And what else is happening physically?
There are some hemodynamic changes too. Your heart's pumping more blood faster, the preload and afterload increase. This physical stress can literally stretch or aggravate areas of fibrosis or scar. Plus, fluid shifts during exercise can potentially change local electrolyte concentrations around the cardiac myocytes, which might also promote beads or arrhythmias.
And what about metabolic changes?
Lactic acid builds up during intense exercise, and that can have some proarrhythmic effects. And in people with those underlying channelopathies we mentioned, like CPVT, the catecholamines released during exercise directly worsen the ion channel malfunction.
Is there something particularly ominous about arrhythmias happening during exercise?
That's a great question, Ash. Unfortunately, yes. VTAC or VFib that occurs during exertion is generally associated with a significantly higher risk of sudden cardiac death compared to arrhythmias that happen at rest. Some studies suggest the risk could be up to 8 times higher.
And exercise stress testing can confirm the link, assess risk, and sometimes guide therapy, especially for patients who have exercise induced ventricular tachycardia but haven't had an arrest yet.
That's right, Ash. Now let's shift focus slightly to the MRI findings. The late gadolinium enhancement, or the LGE. How does seeing that actually refine our understanding of the patient's risk?
The LGE is an incredibly powerful tool for risk stratification. Think of it as a scar map. It visually identifies areas of damaged, electrically unstable tissue. Multiple studies show that the presence of LGE significantly increases the odds of life threatening arrhythmias and sudden cardiac death, 5 times higher or more. And importantly, this is often independent of the ejection fraction.
What about the EF? Does this occur even if the EF looks okay or normal?
Even if the EF is relatively preserved, yes. And it's not just present versus absent. The scar burden matters. Some research suggests that for every 1% increase in the extent of LGE relative to the total heart muscle mass, the risk of sudden death might climb by something like 11 to 15%.
Wow. Are there any specific cutoffs that we look at?
There are some emerging thresholds. For example, in hypertrophic cardiomyopathy, scar involving 15% or more of the left ventricle mass is considered a major risk factor. Even small amounts like 5 to 10% is concerning. If we look at the annual mortality rates, patients with LGE might have a rate around 4.7% per year, similar to known coronary artery disease patients, whereas those without LGE might be closer to 1.7%. It's a significant difference.
So that's indeed a significant difference. So does the pattern or the location of the scar matter too?
Yes, it does. For example, mid-wall scar, often seen in dilated cardiomyopathy, carries a high risk. The inferolateral pattern, like in our patient, seen after myocarditis or sarcoidosis, is strongly linked to developing ventricular tachycardia. Different patterns hint at different underlying causes and risks. So, given how important LGE seems to be, how does this fit with current guidelines for deciding who needs an ICD, which often focuses heavily on the ejection fraction?
Great question, Ash. I think that's a key discussion happening right now. Traditional guidelines often use an EF cutoff of 35% or less as a major criterion for primary prevention ICDs. But the LGE data shows we might be missing high risk people who have better EF, say 40 to 45%, but who might have extensive scarring.
So, the guidelines may need some updating, huh?
I would say they're evolving. Newer guidelines like the 2022 ESC guidelines for hypertrophic cardiomyopathy are explicitly incorporating LGE into risk calculators. And there's growing consensus that LGE should be strongly considered in that gray zone EF population that we talked about, maybe 36% to 50%, especially if they have other risk factors. Which brings us to maybe the most critical part, especially given this patient's journey: management for young patients with recurrent VTAC or refib. What are the key considerations and what can we take away from the delay in getting an ICD here?
Well, for secondary prevention, an ICD is a class 1 recommendation. The strongest evidence supports it. The data is overwhelming. ICDs significantly reduce mortality in these patients. We are talking reducing the risk of death over several years from maybe 10 to 15% down to less than 5%, especially if they have LGE.
And choosing the type of ICD, does that make a difference?
That depends. If they don't need pacing for a slow heart rate, a single chamber ICD might suffice. For younger patients, sometimes a subcutaneous ICD, where the lead goes under the skin and not in the heart vessels, is considered to avoid long term lead complications. And if they also have poor coordination of the heartbeat, like a left bundle branch block and a low EF, then cardiac resynchronization therapy with a CRT-D device that combines both pacing and defibrillation might be the best option.
Correct. Okay, what about the life vest again? Why isn't that a long term fix?
It's just not designed for that. It's a temporary bridge, maybe while waiting for an ICD, or if the risk is thought to be transient. But relying on it long term in someone with a proven high risk, well, we saw the potential consequences. Compliance is one issue, but also studies show that having another arrest while waiting can significantly increase mortality compared to getting the ICD promptly.
These are all great options. And the most important thing is not that one of these is better than another. It's that you have a series of different tools so that you can pick the best defibrillator or defibrillator pacemaker combination for your patient. And in young patients like this, a sub-Q ICD, you're going to have this for a long period of time. Not having something intravascular really helps reduce the risk of infection long term. But a sub-Q ICD comes with a couple downsides. For anyone who has ever seen these, the can is massive. It's almost 3 times the size of a normal defibrillator can. It goes left lateral, and it's not the most comfortable. It's not cosmetically appealing. And because it is sitting outside of your sternum, it is susceptible to T wave oversensing and some risk of inappropriate shocks there. And it cannot do any sort of anti-tachycardia pacing or ATP, which is a method where you can pace the person out of ventricular tachycardia without needing to shock them, which is obviously much more comfortable for the patient. Are there other options for extravascular defibrillators that could be considered in addition to the subcutaneous ICD?
That's a great question, Colin. The EP community has identified so far the drawbacks of the regular traditional transvenous defibrillators and their long term complications. And so, this idea of implanting the lead in the subcutaneous region has become very popular. But taking a step ahead to compensate for the inadequacies of subcutaneous ICD, as it cannot provide anti-tachycardia pacing like a transvenous defibrillator, we now have the extravascular ICD, which is becoming quite popular. The advantage of extravascular ICD, where the lead is implanted right beneath the sternum over the pericardium, it can provide anti-tachycardia pacing to pace the patient out of the abnormal heart rhythm before giving them a defibrillation or a shock.
That sounds like that would potentially be another great option. Obviously, this is not any sort of infomercial for EV-ICDs or
Right.
sub-Q ICDs or the pros and cons of either one, but it's just important. The pros of an EV-ICD are a lot smaller generator, better cosmetic result, and the ability to ATP patients. Whereas the sub-Q, it is much old. It is a device that has been on the market for a lot longer. We have a lot clearer idea of the pros and cons of it and the long-term complications related to it. I think so far at Penn, we put in 45 plus EV-ICDs at this point, and we've had a very great experience with them. But it is important to just, as a cardiologist or an electrophysiologist, to understand what your options are so that you can provide the patient with the best options possible.
Agree. And this is what shared decision making is about.
So, Ash, my next question is, what are the medications in managing this long term?
Well, medications do play a role, but often as adjuncts to the ICD and not replacements. Amiodarone can suppress VT, but has long term side effects thyroid, liver, lungs, etc. Beta blockers are usually first line, especially for exercise trigger VT, because they blunt that adrenaline effect, but they don't prevent sudden cardiac death as reliably as an ICD does.
What about ablation, burning that arrhythmogenic substrate?
Catheter ablation is a very important option, especially if someone is getting frequent VT or ICD shocks despite medication. The goal is to target and eliminate that arrhythmogenic substrate, that scar tissue causing the re entry. For scar related VT, success rates, meaning freedom from VT recurrence, could be pretty good, maybe 60 to 80% in experienced centers. It can significantly reduce shocks, improve quality of life, but it can be complex, especially if the scar is deep in the muscle wall.
Thanks for that explanation. And in a patient like this with recurrent exercise-induced ventricular tachycardia, what lifestyle changes are recommended?
That's crucial too. Definitely need tailored exercise restrictions based on what triggers their arrhythmias. Stress management can help, avoiding certain drugs if they have long QT syndrome, etc.
So, looking back at this case, the decision to delay the ICD after the first event really had devastating consequences, didn't it?
It unfortunately did. The subsequent arrest led to the kidney failure, the dialysis requirement, the anoxic brain injury. It's a stark reminder of how critical shared decision making really is, explaining the risks and the proven benefits of the ICD, and especially the type of ICD to younger population who might be understandably hesitant about an implanted device, because ICD is truly the only safety net here.
This is a very important point. None of these things preclude you from recommending an ICD in this patient. But I also would want to echo the other way around, which is you cannot only recommend an ICD in this patient. It's important to recognize that an ICD is not a treatment for ventricular tachycardia. It's a treatment for sudden cardiac death, right? And it likely would have prevented this guy's sudden cardiac arrest, which obviously had devastating consequences, which is very sad and unfortunate. But you don't want to just put an ICD in and then have the patient get shocked every time they exercise. That's not a solution to their ventricular tachycardia either. This is definitely a situation where I think a very detail-oriented catheter ablation could significantly improve his long-term quality of life. There are a lot of tools that we have these days. Even in a guy like this who has sub-epi substrate, you could get a very good idea without having to go epicardial with coronary venous mapping, whether you think that the critical circuitry is in the epicardium, and then get epicardial access and target epicardial scar, endocardial scar, plus or minus venous alcohol if there's things in between that you can't get to. But in a lot of these cases, though, the overall, you can never say, not never, but for the most part, we don't permanently cure people. You can get really good long-term outcomes for patients with catheter ablation, especially in a young person like this, where what you're talking about is either committing him to an entire lifetime of medications, he's only 30, or doing that and telling him you're never allowed to exercise again, right? There are consequences to that. Not only are there lifestyle consequences, there are cardiovascular consequences to him never being able to exercise again in terms of his long-term health risk factors, his likelihood of getting coronary disease, etc. So I really think a detailed effort to try to actually address the underlying problem and substrate here with catheter ablation in this young patient, if he were to recover neurologically, would be the best approach to try to establish some long-term quality of life for him.
In conclusion, this case really highlights the power of that EP study in methodically narrowing down the cause.
The mapping really pointed out to that localized scar being the culprit, guiding potential therapy like ablation and ICD, and arguing against maybe a more diffuse progressive cardiomyopathy being the main driver.
So let's wrap this up. Key takeaways for everyone listening from this deep dive.
First, the crucial role of electrophysiology studies. They can really uncover these hidden arrhythmogenic substrates, especially in seemingly healthy people whose arrhythmias only pop up when they exercise.
Second, the power of cardiac MRI, specifically LGE. It detects subtle but critical scarring that other scans might miss, even if the heart function looks normal.
And third, don't underestimate the clues in the EKG during the VT itself. The pattern, that morphology, can really point you towards the origin and the likely mechanism. Structural scar versus channelopathy.
Fourth is the importance of substrate guided ablation in treating these arrhythmias, in addition to ICDs to prevent a sudden cardiac arrest for secondary prevention.
So, and fifth, this idea that scar mediated ventricular tachycardia isn't always static. New arrhythmogenic areas can potentially develop over time within or around the scar, reinforcing why long term protection with an ICD is often necessary, even if ablation is also performed.
That's very true, Juma. What a fascinating and multi layered case. We've taken quite the journey through the complexities of cardiac electrophysiology here, from the initial presentation of life threatening arrhythmias in this young man to the advanced diagnostic workup that ultimately revealed the hidden culprit. the subepicardial scar tissue acting as an arrhythmogenic substrate.
I agree, Ash. This was a very complex case indeed. And for those of you listening, thank you so much for joining us in this deep dive of cardiac electrophysiology. And we should all do this again.
Thank you guys. That was just an absolute masterclass.
So, next for the expert commentary, we have the electrophysiologist, Dr. Mohammad-Ali Jazayeri. He's a clinical electrophysiologist working at Trinity Health Livonia Hospital, who is also part of Michigan Heart. He also managed this case firsthand, so he will be providing some expert commentary on this case and also some comments about the EV-ICD that was placed on this patient.
Hi, my name is Ali Jazayeri. I'm a clinical cardiac electrophysiologist at Trinity Health Michigan Heart in Ann Arbor, Michigan. First off, I want to start by thanking the CNCR team for having me on to provide commentary on a very interesting case presented by my colleagues, Dr. Firos and Verma, who I think did an excellent job of laying out the case and some of the discussion points that followed. And so I will try to summarize the case first and then add some additional perspective. In brief, this was a 30-year-old young man who presented with out-of-hospital cardiac arrest due to exercise-induced ventricular tachycardia. He had a previous history of this dating back to approximately 2021 and had undergone fairly extensive evaluation, including cardiac imaging, as well as invasive EP study, and ultimately had been recommended by more than one electrophysiologist to undergo ICD implantation for secondary prevention of sudden cardiac death. He ultimately elected not to do that and had an alternative strategy of a home-mounted AED, but unfortunately, a number of years later, he developed a recurrent arrhythmia in the setting of high levels of exertion, and that's how he came to our attention in Trinity Health. And as mentioned by Dr. Firos and Dr. Verma, the patient was quite ill on arrival. He had been resuscitated, required extensive vasopressor support, multi-organ failure, severe metabolic derangements, ultimately required hemodialysis. But due to his young age and resilience, he was luckily able to get through all of that. And I became involved in his care at a time when he was being considered for ICD implantation. He did suffer an anoxic brain injury, but ultimately had pretty good neurologic recovery, and so was able to participate in that conversation, which I'll talk more about. Taking one step back, in this patient's case, he had a known history of exercise-induced ventricular arrhythmia, but we do not always have the benefit of having that background information on patients who present with symptoms concerning for an exercise-induced arrhythmia, and specifically a ventricular arrhythmia. And so I think for our audience, it's important to keep in mind some simple things that we can all do so that hopefully we can catch these types of diagnoses, which are somewhat rare and may not be present in routine practice all the time. Confronted with a complaint of exercise-induced arrhythmia, it's useful to understand at what point during the exertion someone may be experiencing arrhythmic symptoms. So whether it's happening with peak exertion, which might be more suggestive of a structural heart problem or an ischemic process, or if it's happening during recovery, which can sometimes be seen in inherited conditions like CPVT and long QT syndrome. Family history, which in this patient's case was not particularly remarkable, but sometimes can give clues as to what condition the patient may have, having an understanding if they have any congenital heart problems, and then a social history, understanding any ingestions, illicits, herbal medications, over-the-counter medications, stimulants that the patient may use. These can all help to clarify the differential diagnosis before honing in. ECG was quite important and was on display in this case when it came to localizing the arrhythmia. And it was quite elegant how the predicted site of origin based on the 12-lead ECG morphology coincided with MRI findings and then EP study findings. Not always the case. We are often asked to deal with conflicting evidence in electrophysiology, but in this case it was nice to see. But just taking a step back again with ECG, outside of localizing VTs and making the diagnosis of VT, there are other clues, subtle clues that sometimes can raise awareness about a condition that may predispose individuals to exercise-induced arrhythmias. Some of these include abnormally long or short QT interval, Brugada ECG pattern, which although not particularly common to have Brugada syndrome in North America, but somewhat prevalent on a global scale and should be kept in mind. epsilon waves, which may suggest ARVC. And even if epsilon waves are not present, sometimes abnormal T-wave inversions in the precordial leads. Pre-excitation, certainly something we don't want to miss. The signs of abnormal hypertrophy, which could point to hypertrophic cardiomyopathy or potentially other myopathies. And then something else that did come up in this case, which is any PVCs that you might see or non-sustained VT. In this patient's case, on an earlier admission, he was noted to have salvos of a non-sustained VT, and sometimes these can be fortuitous in that if you understand the morphology and can capture them, they can give clues as to where the sustained arrhythmia was coming from, particularly if we can correlate that with structural heart findings on MRI, for example. Exercise stress testing, not necessary in this particular patient, but in a patient who you're suspicious about exercise-induced arrhythmias, it's certainly nice to be able to prove that in a supervised environment with a 12-lead ECG, and then also this gives insight into at what point during the exertion the patient may have had the arrhythmia, whether it's during peak exertion or during recovery. Some of the hallmark things, often tested concepts for trainees include the bidirectional VT, certainly makes you think about catecholaminergic polymorphic VT or CPVT. VT during recovery makes one think sometimes about long QT syndrome, particularly type 1 long QT syndrome. Other diagnostic evaluations that were done in this case included transthoracic echocardiography, which showed an EF of approximately 40%, a cardiac MRI, which we'll talk more about. Sometimes in a patient in whom you are considering this diagnosis, ambulatory ECG monitoring can be quite useful, especially if you can get 12-lead ECG. Ambulatory monitoring typically can be done for 24 to 48 hours, but not always available. But in the right patient, this can be very useful in understanding PVC morphology, VT morphology, and so on. And so that takes us then to the other evaluations the patient had in the hospital. I didn't mention it here as a possibility, but in this patient's case, cardiac catheterization was useful. He initially presented with some ST segment changes that were difficult to interpret. Ultimately, I think probably related to his metabolic dysfunction, but was taken to the cath lab where it was noted that he had normal coronary anatomy. He did not have anomalous circulation. He, through a variety of studies, was known to not have a history of congenital heart disease. And so these are other things that one should consider when confronted with an exercise-induced ventricular arrhythmia. His echocardiogram showed a reduced EF, which was pointed out by my colleagues, an EF of 40%, which coincides with some degree of structural heart disease. And in his case, I think most likely a non-ischemic cardiomyopathy. And then subsequently, cardiac MRI showed fibrosis in the basal left ventricle, which then was later studied with EP study. And as was mentioned by our CNCR host, this sometimes can prove very fruitful as a target for catheter ablation, and certainly in a patient with recurrent arrhythmias, that is an optimal treatment strategy to avoid long-term antiarrhythmic medications and their complications and side effects, and also just to try to restore these individuals who are quite traumatized by all of the events they've gone through to some semblance of normalcy and a normal life to the extent possible.
So moving on from there, one of the elements that we didn't touch on, it was mentioned, but I think merits consideration as well, as genetic testing. We didn't have the benefit in this patient's case of having that information available at the time when he was being evaluated and treated, but certainly can be useful both for understanding a patient's diagnosis and optimal management, but also when it comes to counseling family members, particularly in this person who is young and may want to have a family in the future. Beyond that, it's worth discussing secondary prevention strategies and how we evaluate patients for a defibrillator. It was an excellent discussion that was held with the team on this podcast regarding different types of defibrillators. And so from my perspective, I often evaluate patients by looking at a sort of stepwise algorithm of what their overall needs are to help identify and land on what is the optimal device. And this is done through the process of shared decision making. I think salient points for this particular patient include the fact that he has no pacing indication. His resting heart rate was somewhere in the 80 to 90 beats per minute range, even on beta blocker therapy, so certainly no pacing indication. He's young, he's active, he's in his working years. I think all of these are very relevant considerations for patients who require a defibrillator. And so really a traditional transvenous device, while it would meet his needs, probably is not the optimal device because he doesn't need pacing. He's not a candidate for cardiac resynchronization therapy due to his neurocurus complex and lack of ventricular dysynchrony and lack of heart failure. And so Really, he needs a device that can defibrillate him effectively and potentially provide ATP therapy if his VT is amenable to that. He had monomorphic VT that was captured, again, very useful when being confronted with a patient with ventricular arrhythmias to try and capture a 12-lead ECG. Oftentimes it doesn't happen in the rush to treat the patient, but can prove very useful in a variety of ways, as we've already discussed. And for that reason, I wanted to offer him a therapy that could give him ATP or anti-tachycardia pacing for treatment of his VT should he need it. And so among the extravascular devices which are available, meaning a defibrillator that does not have a transvenous lead going into the vasculature and into the heart itself, there are two options. There's the Boston Scientific subcutaneous ICD, which has been commercially available since the early 2000s and was really first to market as an alternative to transvenous ICD. There's also the newer Medtronic Aurora EV ICD or extravascular ICD, which is similar in that it's extravascular and subcutaneous, but the lead is in a substernal position. So both of these devices have a generator that sits somewhere near the anterior mid-axillary line, but the electrode for the device can be either on top of the sternum, as in the case of the SICD, or under the sternum, as in the case of the EV-ICD. There are some other pertinent differences between these devices. The EV-ICD pulse generator is somewhat smaller. It is very similar to Medtronic's traditional transvenous generator, which may prove beneficial for people who are slight of frame. Younger patients with minimal body fat might benefit from this. And then the estimated battery longevity is a little bit longer with an EV-ICD, and so in some studies, it's been estimated that patients can save themselves up to 2 generator replacements over the course of a lifetime, if we think of how many years they may be benefiting from defibrillator therapy. So these are some of the differences, but subcutaneous ICD, as was mentioned, has been around longer. We have more clinical experience with it. It's been more studied. We have long-term outcomes over years, over 10 years, and so that's not to be diminished in any way either. So beyond that, actually, there's a small rate of failure with the EV-ICD, less than 2%, where the lead can't be positioned in an adequate fashion such that the device can't be guaranteed to effectively sense ventricular arrhythmias and defibrillate them. So typically in my discussions with patients, I have a plan A and a plan B and sometimes a plan C. So if plan A is extravascular ICD, I typically screen them for subcutaneous ICD to make sure that they fit in a number of vectors that the SICD can record in. And then if for whatever reason both of those options are not fruitful, then we have transvenous ICD as sort of a last resort so that the patient can have defibrillator therapy, but something that's customized to their specific needs. In this patient, he, after having this discussion, was very much interested in EV-ICD, so we ended up performing that for him prior to discharge. He did very well with that. The procedure went smoothly. During EV-ICD implant, there is still a required defibrillation threshold testing, so we induced VT, actually VF, during the procedure and then watched the defibrillator detect it appropriately and shock it and restore him to sinus rhythm. And so with that concludes my thoughts regarding the case and additional points for the audience members to consider. I think this was a very interesting case, certainly not one that we see often in electrophysiology practice, and so it was useful to have benefited from the work that was done by other electrophysiology colleagues at other institutions, but ultimately it was gratifying to be able to get him ICD therapy and also stabilize him in a way that hopefully moving forward he won't have such dramatic events and hospitalizations, and hopefully can get back to a productive life. Thanks again for your attention. Thank you for having me.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marques. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.